talks. We have the great honor of having with us Dr. Sonal Tulli. I think she needs no introduction. A person whom I admire for the way she teaches about keratitis, and I was worried that I was going to miss her talk as the timing was the same, and it's fortunate that we will be listening to her first on her keynote address in infectious keratitis. Dr. Sonal, over to you.
Up my talks right now. Can you load up the talk, please? Thank you. So I want to thank the organizers for inviting me here today. This has been great. I haven't been to AIOC for a few years now, and I haven't been to India for 3 years, so this is really nice to see everybody in person and be able to talk to people. I'm going to give a very short talk. I know you're looking forward to hearing about cross-linking, but the talk I'm going to give about is sort of related to the previous talks about keratoplasty. So what do you do when you don't have corneal tissue? I have no financial interest to disclose. So what are some of the reasons why we do keratoplasty? So some of the optical reasons where you want to improve the vision of the patient. You have therapeutic indications where you want to fix a problem that you see on the cornea that you can't fix otherwise. And then there's a tectonic indications where you want to treat the cornea or maintain the structure of the cornea because the cornea is getting damaged. So why do we need alternatives? Why not just do keratoplasty in everybody? Well, some of the reasons are better known to you than to me. In the US, we have plentiful tissue, and we never have a problem with corneal tissue, though we did have one recently because we couldn't find Optisol. But there's less corneal tissue. Sometimes the patients are high risk. You cannot take them to surgery. The eye is high risk. They just don't have healthy tissue that you can do a transplant with. And patients who might not have good vision, and then you don't want to waste corneal tissue on somebody who wouldn't see well. You're doing it just to save their eye. And some patients in the US will not take tissue from a donor because it's somebody else's tissue. So here's a patient. We'll start with very simple. So simple, this is limbal stem cell deficiency in this patient that has ectodermal dysplasia. And this is both eyes are similar. So you cannot take a slet from the other eye. And a poor prognosis, young patient, so you do not want to put them on immunosuppression for a long period of time. In these patients, the major cause of decreased vision, and this patient was 660 in his eye, is because they have irregular corneal surface. And all you have to do is put a hard contact lens on the surface of the eye or a scleral contact lens, and his vision immediately improved to 6.6. And why is that? And it's because when you have an irregular cornea, so conjunctiva over the cornea is very irregular, and so light gets scattered and you cannot see because you're seeing irregular images, something like what you would see in keratoconus. If you put a hard contact lens, now you have, can you see my, yeah. So now you have a smooth surface that the light is getting refracted by, and the fluid from the tear film fills in all the nooks and crannies, and the vision improves, and you get a nice, sharp focus. But in patients where you have more scarring, so this is a patient with granular dystrophy, you obviously cannot just put a contact lens on top because these lesions are deeper. So they're deeper into the stroma, though they are extending into the epithelium, as you can see, but they're pretty diffuse and confluent. So patients can't see with a contact lens. And so what you need to do is you do PTK or do a keratoplasty or keratectomy with epithelial masking. So you do not take the epithelium off, unlike what you would do with PRK or PTK. And here's a sample of what happens. You've got these granular lesions into the epithelium and into the stroma. When you start lasering, you see the autofluorescence from the epithelium. And as you laser down, you laser epithelium here and then just the lesions in the center. And so you'll start seeing the lesions appear. You'll still see autofluorescence from where the epithelium is intact. But where the lesions start showing up, now what you're doing is lasering epithelium in some places and the lesions in the other, the granular lesions in the other. And as you keep moving down, now you eventually end up with a very smooth cornea. This patient actually had deeper lesions too, which we could not remove, obviously. But he did really, really well. His 6, 7.5, and has maintained this for at least 7 years now. So is very happy, has never needed a transplant. This patient, though, unfortunately had very poor prognosis, HSV, herpetic keratitis, recurrent episodes, could not resolve this with medications, and he kept getting intermittent epithelial and stromal disease. And so what we ended up doing was a very, very thin Gunderson flap. They just wanted ambulatory vision, was an elderly patient, and even through this Gunderson flap, they could get 660 vision, and were very happy because now they had serum-based growth factors in the cornea that prevented them from getting ulceration. Similarly, with this patient with a neurotrophic ulcer, this is a peripheral ulcer, so you don't have to cover up the entire cornea. You can put a pedicle graft over the eye. The neurotrophic ulcers develop because there's no growth factors, there's recurrent trauma, so they cannot heal themselves. There's no tear film. If you put a pedicle graft over the eye, now they've got serum-based growth factors, they've got fibrovascular tissue that doesn't get ulcerated very easily, and this patient maintained very good vision through the central cornea, despite having this conjunctival flap in the periphery. For these really tiny peripheral ulcers or lesions, this was a patient that one of my residents tried to remove a rust ring using a drill and went right through the cornea and got a nice little hole, flat AC. And all you have to do is put glue on there. The glue stays on there for 3 months or so. Epithelium and stroma grow back underneath, and you get fibrovascular tissue. The glue then falls off, and this patient never needed surgery with 6/6 vision permanently after that. So this was a very good outcome. What you don't want to do with glue is to remember that when glue polymerizes, it forms a little mountain on the eye. And so what you don't want is this excessive glue, because then you cannot put a contact lens and keep that glue from falling off because the lid keeps hitting it. One other way of doing that, especially if you have a very large lesion, is to use the Drape method, which we use a lot. Take a punch and punch out a little disc of drape. Take glue and put the little disc of plastic on the Q-tip with some ointment on it, and then you put some glue over that. And now what you do is dry the eye. You always want to make sure that the perforation is very, very dry before you put glue on it. Otherwise, the glue will polymerize to itself and not to the edges of the wound. So dry the ulcer, and then put your little drape with the glue on it on top. And now you get a nice little flat disc on the eye. The eye is very, very smooth, and this can stay there for months, and you put a contact lens easily over it rather than a big mountain of glue. Sometimes you want to get some, glue is very inflammatory. It's good for peripheral lesions, but not very good for central lesions. So if you want to treat a central lesion, and especially if you want to reduce the inflammation in the eye, what you can use for these patients, this patient had poor prognosis, had a meningioma removed, so did not have good visual prognosis, and so we put a multi-layer amniotic membrane on the eye, and that got incorporated into the cornea, the epithelium grew over it, and she never needed eye surgery, was very happy because she didn't need to go to surgery. Sometimes you really have to take out your tool belt and think your way through things. This was a lady who had a PKP 25 years ago, so very old PKP, fell and hit her eye on the doorknob and came in, had left her cornea on that doorknob, so she came in basically with an empty eye. You could look into that and see her optic nerve. The vitreous was gone, the iris was gone, the lens was gone, and the cornea, of course, was gone. She was eating when we walked into the emergency room to see her, so anesthesia refused to take her to the operating room until she had done NPO for 6 hours. And so we had an empty eye, and we had to figure out what to do. So what I did was we took a bandage contact lens, a simple AccuView, zero power contact lens, put it on the eye, and glued the edges of that to the eye to form a pseudocornea. And then we put a larger contact lens on top, and this is how she maintained her eye until we could take her to surgery the next day to get her eye fixed up. So take-home points from this: if you have an optical problem, take a look and see what's causing the optical problem. If it's an irregular surface, you can put a hard contact lens on it to smooth the surface, and you'll get good vision without needing any surgical procedures at all. If it is a scar or granular dystrophy or other things that are blocking the vision, do a PTK or a lamellar keratectomy to remove that scar, and you'll get good vision. If it's a therapeutic indication where you need growth factors, put either conjunctiva on there, or you can put a bandage contact lens. And for tectonic lesions, you can put conjunctiva, you can put glue. Glue is actually a really good alternative for peripheral ulcers permanently. And then you can also use amniotic membranes or Tenon's capsule. That's it for a short presentation on alternatives to keratoplasty. Thank you.
Thank you, Dr. Sonal. May I request you to join us on the dais along with the other panels, if it is okay with you. And Dr. Fogla as well, please do join us on the dais. We now have a galaxy of speakers who will be speaking to us on the practice patterns in the management of keratoconus. The first talk will be of Professor Radhika Tandon. She is not possible to join us in person because of her administrative duties. So her talk is a recorded version and it will be played on. She's going to speak to us on classification of keratoconus, the pentacam interpretations, refraction and contact lens pearls, and decision making in keratoconus. Can I request the audiovisual to please start the talk?
To Professor Vanathi for inviting me to participate in this instruction course. I'm going to take you through the classification, giving a few tips on pentagram and interpretation, as well as some practical pearls on refraction and contact lens fitting in keratoconus. In the interest of time, I shall be highlighting the main points and leading you to the correct sources for information. This is a summary slide of the main characteristics of keratoconus. Apart from the signs and symptoms, it's important to be aware about the known information regarding the etopathogenesis, the various causes, and the pathology. This slide summarizes the main clinical features seen on slit lamp, illustrated by images taken from our clinic. Apart from hereditary features, there are known mechanical risk factors in keratoconus, particularly eye rubbing, which may be due to various causes. And knowledge of this is important not only for the doctor, but also communicating this information to the patient so that they can be cautioned to restrict eye rubbing, which is both important not only for the occurrence of keratoconus, but also contributes to progression. And even after treatment intervention, if eye rubbing continues, it can limit the outcomes. There are several excellent classification systems of keratoconus, and each has its role to play. In the current context of this instruction course in present day times, I would like to highlight the ABCD classification described by Michael Bellin et al. It uses modern technology, essentially corneal tomography and Scheimpflug imaging criteria, separating the features in terms of A, the anterior surface, B, the back surface, C, the corneal thickness, and D also takes into account the best corrected distance visual acuity. And along with that, there is also the component of scarring, which is taken into account, so that for each patient you can customize the exact parameters and come to a more defined value of the stage of the disease. Continuing from the previous slide, this slide is summarizing the main criteria or the cutoff values which are useful for identifying the cornea at risk. These are largely used for screening patients for refractive surgery, because one would not like to operate with a corneal refractive procedure in a patient who has either got subclinical or is prone to keratoconus. It's very useful to have these criteria available handy near the pentacam machine or in the clinic. And just for an example, I would mention that in the sagittal map, it is not only one criteria which is taken into account. It is several of these factors which have to be screened, because there are patients who may have normal values for one or two parameters and abnormal for the other. So let's look at an example. This patient has keratometry values K1 and K2 within the normal range, and even the Kmax is below the cutoff. The thinnest spechometry is suspicious at 470 microns, but the maps do not show any remarkable changes of keratoconus. This is when the Bellin-Ambrosio enhanced ectasia display, known as the bad display, comes into help, because with this display, the computer or the software excludes or deletes the data 2 millimeters, or you can set it to 3 millimeters around the thinnest point. The assumption is that this is the abnormal area, and excluding this from the calculation of the best fit sphere enhances the abnormality of the cornea in comparison. And it's very beautifully seen in this illustration how now we are seeing the red zone visible to show that there is an elevation anteriorly as well as posteriorly. And if you look at the corneal thickness spatial profile as well as the percentage thickness increase, here again one of them is showing within the range, a little on the higher side of the 2 standard range, and as you can see, the percentage thickness increase is dipping down below the 2 standard deviation limit. So this is definitely a suspicious cornea, and then now the software gives you nicely a D value and also a color-coded red flag to indicate that this is an abnormal cornea, likely to be keratoconus. So in concept, we have a spectrum of corneas. On one side you have normal, and at the other extreme you have keratoconus. And in between, you have an area which is gray. It could be considered subclinical keratoconus, it could be keratoconus suspect, and within this, it could either be a form-fruit keratoconus, which is like an arrested form of the disease, or it could be early keratoconus, which is subclinical now, and with time may progress into a full-blown disease. Here is an example of a corneal variation where the anterior surface of the cornea is normal and the disease disorder is present on the back surface. So an irregular cornea leads to irregular refraction and there is poor prognosis for spectacles for vision correction. However, a contact lens, by regularizing the corneal surface and the irregularities, masks the problem and acts as a regular front refracting surface and can therefore give better vision in cases where spectacles are not useful. Just a quick word about refraction. The retinoscopy reflex is distorted, it may be swirling and scissoring, and there's a high amount of irregular myopic astigmatism, which leads to a challenge in deciding which reflex to neutralize. So this is difficult. It requires experience, practice, and time. An illustration, there's a patient with moderate and advanced keratoconus, bilaterally affected, using spectacles, but having troublesome glare and halos with driving and difficulty in face recognition. And with a contact lens, the patient was able to get full vision of 6x6 and was comfortable and was able to avoid surgery. These are the fitting parameters for the patient, and a quick word about the contact lens fitting philosophies. Apical clearance indicates a steep fit, and earlier this was taken as acceptable. However, it is known to lead to hypoxia and neovascularization due to lack of tear exchange. And apical bearing of the contact lens with a very flat fit can lead to apical scarring and should also be avoided. So for an optimal lens fit, there should be an optimal lens movement, about 1 to 2 millimeter movement with a blink, which facilitates proper tear exchange, and this can also be checked by looking at the peripheral pooling and indicative of the edge lift. Illustrating the importance of focusing on the edges as well. If using the first try lens, the parameter that one looks at is the lens diameter as well as the sagittal height of the cornea. Must evaluate the tear film, and one aims to have an ideal tear vault of about 150 to 250 microns at the highest point. So in a nutshell, the decision making, A, is to make the diagnosis, to arrest progression by early detection, and also avoid inadvertent weakening by corneal refractive procedures. And the borderline corneas can be quite challenging, and sometimes one can just follow them up and see what happens over time. Further decision making is which intervention and when to intervene to halt progression, and what is the best intervention to enhance or restore vision. I wish to emphasize here that there is a spectrum of disease from normal to abnormal, and high cylinder and steep corneas are red flags in any patient who comes for refraction or even a general checkup, and rapid progression. So these are the key factors In addition, one would have patients who are achieving 6/6, but they're not satisfied. They have some sort of complaint that there is some overlapping, there is some shadowing, etc. So patients who are not easily corrected with refractive errors are the ones which come in the borderline category, and they require careful follow-up and careful evaluation. So the management of keratoconus starts with the making of the diagnosis, establishing progression, intervening, looking at the outcome of arresting the progression, taking the best decision for optimal visual rehabilitation, keeping in account the patient's requirements, the needs, and what is the best suitable option. Hello everyone, it's an honor and privilege to be participating in AIOC 2022, and I'm grateful to Professor Vanathi for
Yeah. So that was a vivid elaboration of the basic principles and approach to keratoconus. Moving on to Dr. Bhaskar Srinivasan's topic, something which is always debated on, something which is still evolving, and we are seeing a lot of advances in this segment. So collagen cross-linking in keratoconus. Over to you, Bhaskar, needs no introduction. A senior faculty and wonderful surgeon from Shankar Nethralaya. Thank you, Bhaskar, and over to you.
Can I have the slides, please? Yeah, good afternoon, everyone, and I'll be speaking on collagen cross-linkage and the variations that we have. No financial disclosures. Basically, in 2003, Wolensack et al. Described the procedure with an aim to improve corneal biomechanics. The minimum requirement of corneal thickness was 400 microns. Riboflavin act as a photosensitizer, and the combination of riboflavin with ultraviolet A led to a photooxidative reaction, which led to an increased corneal stiffness. And the maximum effect was noted in the anterior 300 microns of the cornea. So the basic procedure was called as a Dresden protocol, where there was epithelial debridement, then riboflavin 0.1% was used for about 30 minutes, and then ultraviolet A of 3 milliwatts per square centimeter was used for 30 minutes to get your effect. It is very important to monitor the thickness before you start the ultraviolet A, because there is desiccation which causes corneal thinning, and the dextran which was used in the initial protocol also causes corneal thinning. So when you're looking at indications, basically you're looking at cases of ectasia where there is a documented progression. There are few exceptions where probably when you start off with a very low pachymetry to begin with at the first instance, you might want to do cross-linkage at the first instance. A minimum pachymetry of 400 microns was suggested, but we now have the option of using various techniques to do cross-linkage even in thinner corneas. But what is more important is to know what the vision potential of the patient is, whether the patient is going to be wearing contact lenses or not. There's no point in doing a cross-linkage if the patient is not comfortable with contact lenses or is not going to be wearing contact lenses, in which case you might have to consider lamellar keratoplasty. So when you're looking at indications or in terms of what do you define as progression of ectasia, you have an increase in Kmax, you have an increase in topographic astigmatism, increase in anterior or posterior elevation values. But what is important is actually looking at the difference maps, which gives you a very good idea about subtle progression. And if you have the access to a pentacam, an ABCD progression display of Bellin tells you whether there's a worsening of the anterior curvature, the posterior curvature, or the pachymetric value. So what are the relative contraindications? Would be a cornea which is very thin, but like I said, less than 400, there are options of doing it, and we'll come to it later. Again, a question of when would you, what is a very steep cornea that you would not want to cross-link? The initial Dresden protocol did say more than 60 diopters, they tended to have more of haze. We might still do it in certain select cases, provided the contact lens visual acuity is good and the patient is ready to wear contact lenses. Again, in terms of variation, you can have variation based on the duration. It could be either an accelerated cross-linkage or a UV continuous or a pulsed exposure. You could have an epithelial removal. You could have it based on the change in the carrier. You could have it in terms of the protocols that you use for a thin cornea. You could have a customized cross-linkage, or you could have it what is called as CXL+, where you're doing the cross-linkage and you're trying to improve the vision of the patient also. So when you're looking at duration and intensity, what we call as an accelerated cross-linkage is based on the Bunsen-Roscoe law, which states that if you reduce the irradiation interval but increase the intensity and to maintain the cumulative dose, the effect is the same. But this doesn't work for less than 5 minutes of time if you're increasing the intensity to a significant extent. So generally, at this point of time, what is noted is that an accelerated 10-minute protocol does as well as the customary Dresden protocol as such. Again, when you're looking at epithelium off, epithelium allows a better penetration of riboflavin, allows better UV penetration if the epithelium is removed, and the results definitely state that the epithelium off cross-linkage has better stability as compared to epi on. So at this point of time, epi off cross-linkage is still considered the standard of care. When you're looking at change in carrier, initially it was started with riboflavin in dextran, which was isoosmolar. Now we have the option of a hypoosmolar riboflavin, or you have the option of HPMC-based riboflavin. The advantage of HPMC is it allows a better penetration. It also hydrates the cornea to a certain extent, and the depth of cross-linkage seems to be as comparable to the Dresden protocol. So at this point of time, HPMC-based riboflavin are now known to be safe and as efficacious as the original protocol. When you're looking at thin corneas, there are various ways of artificially building up the corneal thickness by the use of either hypotonic riboflavin, by the use of HPMC, having an epithelium on protocol, or iontophoresis to push the riboflavin into the stroma. Or you can have the option of a customized epithelial removal, where you remove the epithelial island on the thinnest point, or leave the epithelium island on the thinnest point of the cornea. Again, the protocols, because there's an artificial thickening of the cornea, there are areas of collagen-free lakes, and the oxygen permeability through a hydrated cornea is different as compared to a dehydrated cornea. So the efficacy of cross-linkage does vary, and there are contradictory reports which state as effective a cross-linkage in thin corneas as compared to Dresden, versus some which state it is not as effective. The other way of doing a thin cornea CXL would be to use contact lens or a lenticule to artificially build up the thickness when ultraviolet light is passed. Again, the disadvantage of this is the oxygen permeability does get affected, and the contact lens or the lenticule will also absorb some amount of ultraviolet light. The third way of doing it would be what has been proposed by Hafezi, where you are using an individualized protocol where, based on the corneal thickness, the duration of the ultraviolet light can be customized. So you maintain a reasonable amount of efficacy of cross-linkage, being as much away from the endothelium to make it a safe procedure. But again, when you're doing any of these patients with a thin cornea, it's very important to look at the OCT or look at the slit lamp very carefully. So if you're looking at a Pachy map and doing it and you say it's 340 or 350, again, you can look at the OCT, which actually shows that there's an epithelial hypercompensation there. So if you're going to be debriding the epithelium, you will end up with a 280 microns, which might not be safe for you to do a cross-linkage. Again, there is an option of something called as a customized cross-linkage, where you have the UV light applied in 3 concentric zones around the thinnest point, so you have maximum effect of the cross-linkage on that area, helping to regularize the shape of the cornea along with the cross-linkage. And these are the figure on the left basically shows a customized cross-linkage, and on the right shows a standardized cross-linkage. And you can see that the change in the topography is much better in a customized protocol as compared to the standardized protocol. Even the depth of the demarcation line is much deeper in a customized protocol as compared to the standardized protocol. Then you have the option of something called as a CXL Plus, where you can use either laser-based refractive procedures along with cross-linkage to improve the vision, or you can have intracorneal ring segments or phakic IOLs to improve vision once you achieve stability. So you have something called as a Cretin protocol, which basically uses PTK of around 50 microns. So the thinnest point of your cornea, the cornea epithelium is actually a little bit thinner. So when you use 50 microns across, you might actually shave about 10 microns of tissue of the stroma in the thinnest point, and that improves the shape, and that improves the vision of the patient. TREC is a slight modification of the same, using a Schwein platform, where in addition to the epithelium, there's a transepithelial removal, trans-PRK removal of the epithelium, and up to 25 microns of the stroma decentered on the apex of your cone. What is most commonly done is something called as a topography-guided ablation along with CXL, where you need sufficient corneal thickness. The stromal ablation is to be less than 50 microns, and you would want a small treatment zone so that you don't ablate as much tissue, unlike a conventional laser where you actually have larger treatment zones. There is controversy whether you would want to use mitomycin or not in these eyes, with one group saying that you use mitomycin and the other saying that you do not need to use it. But again, the aim of all this is basically to improve the topography, improve the best spectacle corrected visual acuity, and try to improve the vision of the patient along with stabilizing the cornea. So just 2 examples of patients who have undergone TCAT CXL and maintaining vision over almost about a 6-year period. You can have ring segments. Dr. Rajesh would be covering that. So you might have to select that along with cross-linkage in certain patients, like this patient with almost a -12 spectacal acceptance, underwent ring segments first, and he maintains a vision of 4 diopters, vision of 6/12 with 4 diopters, post 6 years of CXL with Intax. You might have to combine all the procedures. So this patient underwent an Intax first, improved his vision to about 612 with a -6 diopter, then underwent a TCAT CXL almost 6 weeks later, and vision improved to 6.9, and this is almost like 5 years post-op. The patient is maintaining vision and the condition is stable. Instead of using rings, you can have the option of using customized allogenic corneal tissue, which Susan Jacob is tried and has published with reasonable success, but it's still early days and we need to look at long-term follow-ups of this patient. Just a couple of examples from her publication showing an improvement in corneal curvature using these corneal allogenic segments as rings. The last option in certain situations would be to use a Bowman's layer transplant to stabilize the condition, and instead of a Bowman's layer, we could probably use a little bit of stroma, which is called as stromal augmentation, with or without CXL to stabilize the condition. In this patient of SJS with keratoconus with a very thin Pachy of 191, we didn't want him to perforate, so we did a stromal augmentation along with, we did the cross-linkage of the stromal lenticule, made a pocket and inserted it inside the eye. And these are just pictures. ICL would be covered by Dr. Rajesh, and basically your glass vision has to be good for you to use ICL after stabilization of the condition. Complications of CXL, failed CXL, we still do not know what is the effect of a repeat CXL. The data is limited in number. And dilemmas are still there. Pediatric patients, whether you would want to cross-link at the first visit or to observe, whether you would want to do a bilateral CXL or you would prefer a unilateral. At this point, I think most of us would probably do a unilateral CXL. And progression, whether you would want to repeat a cross-linkage or not, is again something that we still need to understand more. And the last but not the least, some patients tend to have a lot of stromal haze and a flattening post-CXL. We are still not aware about the reason for the same. Thank you.
Thank you, Dr. Bhaskar. That was a fantastic coverage of all concerns related to collagen cross-linking. There's one thing which I would like to ask as sir is setting up is, what is the thinnest cornea you have cross-linked?
The thinnest I have cross-linked is around 335 on Pentacam. I would definitely want them to first do a contact lens trial before. I've burnt my fingers doing a cross-linkage for 350 and then the patient was not comfortable with contact lenses after that. So then you have actually defeated the purpose. He has to anyway go ahead with the DALC subsequently. You might as well save his time and money and effort in going ahead with the DALC directly.
So on these thin corneas, what is the assisted procedure which you would commonly would prefer?
I do TCAT CXLs quite commonly. If the vision is worse than 6.9, 6.12, I would want to see if I can regularize the topography, keeping it within 50 microns. But I would also look at what his acceptance astigmatism is and what the topographic astigmatism is, because sometimes his acceptance is only -2, but the topography is around -6 or 7. If I regularize it, I'm going to be actually increasing his astigmatism unless I'm able to correct some amount of his astigmatism during the TCAT process. So unless somebody has something somewhere close to around 460, 470 microns of tissue, it becomes difficult to do it.
Okay.
Yes, right.
I think in the interest, we will move on to the next talk of Dr. Samar Basak, who would be talking to us on pearls in the management of high drops in corneal ectasias.
Thank you, Dr. Vanathi, for having me here and include me in your Power Pack capsule of practice pattern. And I do not have any financial interest to disclose. And you know that it is not an uncommon complication of corneal ectatic disorders, especially the keratoconus, and we see also in PMD and rarely in post-lex cases. It is the sudden onset of corneal edema due to break in the DM, and common presentation are sudden impaired vision, eye pain, and eye appearing white. So risk factors are there like atopy, eye rubbing, mentally challenged patient, Down syndrome, and maybe anatomically weak corneas. So the mechanism is acute break in the DM endothelium level and influx of aqueous into the stroma and corneal edema, and disruption of posterior stroma and formation of fluid clefts in the stroma. So clinical examination is very important before managing these cases. Like you may find out fluid cleft in between the edema, and DM break might be visible in certain cases, especially with dilated pupil and retroillumination. Sedal test may be positive, it may be false positive, or actual perforation might. I have seen 3-4 cases, actual perforation happens, in particularly with PMD cases, and you may elicit sedal positivity. Always check the other eye for amount of ectasia is there or not. So the perforation, as I said, that sometimes that spongy stoma, they leaks and it may mimic perforation, so you have to be very careful whether it is a real perforation or false perforation in high drops. Investigation, anterior segment AIOC20, very important to find out the fluid cleft, DM break, scarring, of course, in late cases of presentation. UBM may have similar finding of AIOC20, the imaging, oculizer imaging of the other eye if you get time, and people have done theoretical in vivo confocal microscopy. The treatment, medical management, if you consider that how the natural cause healing occur in 2 stages, reattachment of DM and endothelial migration. So many people actually suggest that medical management and the spontaneous resolution may occur after 8 to 12 weeks, but there is no defined clinical standardized therapy, so we give anti-glaucoma medication, hypertonic saline, steroid drops, cycloplegia, and lubricants. The outcome of conservative measurement at actual scarring, central or off-axis neovascularization is there, and off-axis scar may be improved vision due to flattening, and we have seen a lot of such cases, and improved contact lens fitting. But central scar, of course, need eventual DALC or PK. But the surgical management of acute eye drops is, there are many described, like fluid drainage only, intracameral C3F8 or SF6, compression suture, combination of all above 3 procedure, DALC, PK, or even the EK has been described. There are other rare management has been described like TPK, thermokeratoplasty with or without combined procedure, and publication mostly from China with encouraging results, and intracameral platelet-rich plasma injection that has been also described from Europe. The gas tamponade is basically important. Internal tamponade actually brings the DM break closer to stroma, so isoexpansile gas, longer tamponade, supine position, but there is no change in final outcome in terms of vision and need for subsequent keratoplasty. And compression suture is extremely important from externally. It brings the DM closer to the edematous stroma, works better with interstromal clips. Overlay suture or full thickness suture people have also tried. It should be perpendicular to DM break and combination with gas tamponade. So vending incision is also described, and probably if you have intraoperative OCT, you can see it, or if you have preoperative photograph, you can actually select the site where you could do a vending incision. Like in this case, you see that vending incision, and the surgeon is doing vending incision through the with a 30-gauge needle, and you see the gush of fluid has come out, and you can see from the other side he is also trying to, so fluid has come out. So now you can see the break very well after that venting. So this is very important, and you can put the suture perpendicular this DM tear. So combined procedure with intracameral gas, good outcome, safety and efficacy of the procedure has been reported by multiple publications globally. And I'm sharing a case. This is done by another surgeon. You see that 39 years old lady with sudden DV for 3 days, and you see this is the AIOC20 picture. You see that there is huge fluid cleft, and this is the amount of corneal edema, and surgeon is trying to do first venting incision. You see that similar kind of venting incision is going on, and then another to give little air before putting the compression suture, so give horizontal mattress kind of suture along the perpendicular to the DM tier. So basically externally you fix it. So you can give also radial incision in some of the situation depending upon your tear. So at the end of the procedure, you give little fluid also to check the pressure, then put a BCL, and this is day 7, clear cornea. People kept dilated. This is after 1 month. You see the vertical DM tear. So this is a good technique, and this is the ultimate ASOCT outcome. You see that only little DM scar over that area. So this method works well, and the complications are there: uvulate Jabalia syndrome, pupillary block glaucoma, and complicated cataract. But recently, Sunita and from LVPI, they have described a partial gas field with 80%, instead of 80% gas field, to avoid gas-related complication and quick and fast edema resolution. Last Saturday, we did this surgery. This is the pre-operative. Photo was taken after 2 hours, and post-op photo after 5 years. You see the clearance of this partial airfield, like 40 or 50% airfield. This is working, and you do not have to worry about pupillary block or other uvulate Jabalia syndrome. So other PK and DALK, I think the Rajesh will be talking about it, but manual layer-by-layer technique will be better. And then the people has tried endothelial keratoplasty, also DMAC patch graft or dissect patch graft from inside and air tamponade. So in summary, acute hydrops in keratoconus or other ectasia is not so uncommon. Good slit lamp evaluation and ASOCT may give clue about the size and location of DM tear. Compression suture with partial air-filled intracameral gas and or fluid drainage is the best option. Full or 80% more gas fill have more complication we have seen in our practice. Outcomes are mostly good with further better contact lens fitting later on. Manual DALK or PK with central scarring is the later option. Other treatment may have, you can try in selective cases. Thank you very much for your patience hearing.
Thank you very much, Dr. Basak here. I do agree that compression sutures do result in very rapid resolution. May I ask you, is there any different technique by the way you place your compression sutures?
We go from externally, we don't go full thickness, so only horizontal, and it should be perpendicular to your, like fusiform, usually fusiform kind of DM tear, so your suture should be perpendicular to that, and you must tighten it according to your, put a little bit gash or air so you can tighten it in very nicely. And if you have scope for fluid drainage, that is wonderful because corneal thickness reduced instantly and you could have better tightness of the suture. And you remove the suture after 7 days, 12 days, 15 days, depending upon the clarity of the graft, cornea and also amount of gas inside.
So those are very useful tips there, that you place the suture perpendicular, try to identify the cleft.
These are all 10-0. I have never tried, but I have tried 9-0. 8-0 monofilament nylon is very difficult to get in the market, but 9-0 I have tried with thicker, edema, very thick edema. You cannot see with ASOCT, you cannot cut the posterior.
Yes.
That time you may use the 9-0 because you have a better tightness. 9-0 monofilament, but 8-0 I have never tried.
Because 8-0 Vicryl we use a lot of
Vicryl?
times in, Vicryl.
Oh, I have never.
You're only using it for a week. So
Yes.
if you want Vicryl, it's, you can get better
Gives you a
compression
better
of the
tensile
cornea.
strength and yes, and
Vicryl,
approximation.
okay.
And
So that
used
way
to-
virgin silk can also be used.
Can be used, but that may accumulate a lot because it's braided. Sometimes you may get a lot of
Okay.
discharge or mucus sticking to
The
that suture
80
compared to
vicryl
a-
also polyfilament,
Correct.
polyfilament, not
But I'm
mono.
just thinking in terms of, because 10-0 sutures are sometimes very difficult to get the kind
Break.
of tension,
So,
they breaks. So
nine-
if you use 80 vicryl and you're using it only for a week, if you were keeping it for a month or
Yes.
so, then maybe yes, you keep
Yes.
nylon.
And
But otherwise,
90 we have used in
Rajesh,
thicker.
maybe 10-O vicryl, maybe I will prefer 10-O vicryl because 8-O vicryl, the needle spatulated a little bit, putting it through the cornea,
Yes.
maybe looking.
But 10 of vicryl we have used it, but it is so, I mean, you have to be very careful. The tension, it easily breaks.
Yeah.
That is,
I
and it
do
is
prefer
expensive
nylon,
also.
nylon.
Very much
But of
I
course
expensive.
we
use
have
the
to go
80
for
for traction suture for glaucoma surgery, so it's
Yeah.
not that difficult
Yes.
to take a bite. So I think
yes.
depends on what you're comfortable.
Absolutely.
Thank you,
The
thank
key
you.
point is remember there are interstromal sutures here. Identify the cleft, go perpendicular to it, place a BCL on it always. Helps in rapid resolution. You do not need to use gas intracamerally then. Air works fantastically and does away with the disadvantage of a pupillary block glaucoma in these cases here. So we will now move on to Dr. Revathi's talk. Dr. Revathi is in charge of. Yeah.
Thank you, Dr. Vanathi.
Yes, Dr. Revathi is in charge of the cornea department, senior surgeon, very well known of Aravind Eye Hospitals, Coimbatore. Ocular allergy is a very, very common association with keratoconus, and she's going to talk to us on the practice patterns of management of ocular allergy in keratoconus.
Thank you, Dr. Vanathi. It's very important that you brought out VKC as a separate thing in this discussion of keratoconus because this needs a lot of attention. VKC in a keratoconus or keratoconus in a VKC patient, both this combination is a really worrisome one because VKC can be a predisposing factor and it's a risk factor in VKC keratoconus progression, and as like we have seen, acute hydrops is one of the risk factor. And not only that, in case of management also, to decide on which type of management, VKC can be a deciding factor because it can compromise many of the success of many of our managements. Let us see, the scenario 1 is a child who is presenting with VKC, very severe VKC. So here we have to remember that we have to first differentiate between simple allergic and VKC. Both pathology is different, and if it is a severe VKC, it's going to need a lot of, a prolonged treatment over the years. And we have to remember here steroid is the mainstay treatment, whether we like it or not. We can't just manage these kids only with sodium chromoglycate or mast cell stabilizers, antihistamines, all these things. We cannot manage them because eye rubbing associated with this in this condition can lead on to keratoconus. May not be the main pathology, but that can be a precipitating factor. So we have to really treat this patient seriously. Usually, like we have to explain to the parents, and we can start with the low potent steroids, but we have to taper them very slowly, and we have to explain to them that they may need to be in this medication for many years, and not that like in other conditions where we are going to stop immediately, abruptly or something. And in case of doubtful compliance or the ocular surface is grossly compromised, then we can go for depot therapy also of injecting the steroids in the supratarsal space. But usually I'll go for Decadron first to make sure that they are not steroid responders. And then I'll go for this injection of Tricart. So we have to double evert. First evert the lead and then catch hold. And first we used to, most of the time in children we have to do it under general anesthesia, short general anesthesia, but still I inject a little bit of xylocaine so that post-operatively they will not have severe pain, because this depot injection can be painful even after the injection. Then with using a large bore needle, we have to give this Tricart. And usually this will give a long, at least for few months, they will be relieved of symptoms, and the ocular surface also will be much better than just using topical steroid medications. And another important thing, we have to talk to the parents a lot and convince them that they have to continue this anti-allergic treatment regularly and for a long time to avoid complications like later sequelae like keratoconus. And the second scenario in we already child is having keratoconus and also having VKC. So here we know that VKC can be a risk factor for fast progression. So we have to plan for early C3R. But then again, controlling the VKC well before attempting any surgical intervention is very, very important, because in these patients, chances for infection post collagen cross-linking is more, regional immune suppression, as well as these children often try to touch the eye. They have long-term epithelial problems, healing problems also. Sometimes they can even develop immune infiltrates, need not be only infective. So in these patients, AP on CXL will be a better option than going for scraping the epithelium and then managing the non-healing epithelium. And then even if we are doing it, then we have to keep them in close monitoring till the epithelium heals completely, till we remove the BCL. And we have to differentiate between infective and immune infiltrates also. A sterile corneal melt is another thing which I heard it only in American Academy meeting, but later I come to know that there are reports from India also, and one of the risk factor is VKC in these patients. Usually it occurs within a month time, and it's quite difficult to manage. But we have seen, interestingly, one patient who is a 21-year-old male underwent CXL, but VKC, and he was on treatment. Then due to COVID, he lost follow-up during that time. The CSL was done in 2014, and he presented with central thinning and melt in 2021 during that lockdown time, and with great difficulty because he didn't follow the medications for VKC also. This is not his picture. This is the picture was similar to him, and later this is his picture. I tried even amniotic membrane and all. Then finally I need to do a small patch graft. And acute hydrops, as Dr. Basak told, one of the risk factor, and we have to be very careful in choosing any surgical intervention like compression suture also in these patients, and they are prone for infection, so we have to be very careful about choosing a surgical intervention. And in keratoplasty, definitely they will have more complications than in other non-VKC patients. This is one of from our study which we presented in the morning. DALK in children, in that the VKC group had all complications like epithelial healing problem and vascularization, infection. All those things are more in these patients, definitely, when compared to non-VKC children. So one of such patient, we can see the florid vascularization in the stroma, the interface, because the patient lost follow-up and didn't use the steroids and other treatment. And finally, in this condition, we may have to use steroid as an immunosuppressive sometime, not enough to use it 2 times, 3 times. We have to use it aggressively to control the reaction and reduce the damage. And outcome in VKC compared to non-VKC children, FAC et al., they have done a study in this, and again, visual outcome. And they found out that the astigmatism is more in these patients when compared to non-VKC patients, obviously maybe because of wound healing problems, early suture loosening and suture-related problems. So in conclusion, VKC is a major comorbidity in keratoconus, a risk factor in all stages of this disease and its management. So this subgroup needs more attention and more chair time. And we have to, mainly because most of the time it's a children problem, the parents have to be convinced, and we have to be very closely work with them to reduce complications in these patients. Thank you.
Thank you, Dr. Revati. Until Dr. Rajesh sets up his presentation, where do you position tacrolimus and systemic immunosuppression in VKC patients?
Yeah, sorry, I didn't mention. I mentioned in the slide. Yes, after controlling them with the steroid, even along with that, I used to start either cyclosporin or tacrolimus. Tacrolimus we prefer because one-time application and more economical also. And we have to put them in these medications. And again, some of them can develop problems like chalazion and like hordeolum and all. These patients are more prone for infection also. That we have to keep in mind when using these medications. And systemic is, I think like Gokhale mentioned, like sometimes we have to send them to pulmonologist or allergic specialist even systemic therapy we need to give.
And your comments on doing a cross-linkage for a VKC patient, what are the precautions that you would want to do before you take these patients up for surgery?
First, control the VKC with steroids and other things, though there is a possibility of increased chance for infection during surgery, but still we need to control it completely, either with the topical or depot therapy of steroid, control it, and then we go. And so far, I have no experience in Epion. I think Dr. Rajesh once mentioned that he prefers Epion in children because of this reason. I have no experience. I used to do Epi off only, but we have not come across gross higher incidence of infection. But we always admit these patients for at least 2 days till the epithelium heals, till I remove the BCL, only then I send them off.
I mean, you might just want to be a little bit careful and monitor them closely till the epithelium heals. And if it takes beyond a particular period of time, beyond 4 days that you would normally see, it might even make sense to actually go ahead and do an amniotic or do something to make sure that the epithelium heals. Don't allow the epithelial defect to linger on for a long time. I would now ask Dr. Rajesh to give his talk on refractive procedures in keratoconus, intact phakic lenses, femtodalc. Dr. Rajesh needs no introduction to this august audience as such.
Yeah, one of the things about doing DALC in children with VKC is that you always pre-treat the patients. I always, before surgery, I initiate steroid therapy, and I ensure that the eye is absolutely quiet, because otherwise you do anticipate post-operative problems. You do have epithelial healing problems because of the chronic VKC. They already have a partial limbal stem cell deficiency. So at certain occasions, I have combined my DALC with doing a combined amniotic membrane transplantation at the same time. And I give a supratarsal injection of dexamethasone for all my cases of VKC where I do a DALC, because that helps in the post-operative period, better compliance.
Yes.
And I think from your institute, you, Haripriya, presented injection of triamcinolone, 0.2 cc for cataract surgery patients in the inferior fornix.
Okay.
So I have started now giving that for my DALC patients as well. I don't give it a supratarsal because that's difficult to remove. But if I give it in the inferior fornix, I give a small 0.2 cc of tricot, because in case if he's a steroid responder, it's in an accessible area where I can easily remove it. So that's something that I have taken from your system, and we try to implement in our patients, where it ensures better compliance, because children are not very cooperative with the drops. Parents also, when they apply, the drops don't go into the eye. So sometimes giving that small depot steroid of this thing, it really helps. Now, coming to the topic, at the outset, I would like to thank Vanathi for including me in this instruction course. Refractive procedure in keratoconus sounds contradictory, but that's the ultimate dream of every patient with keratoconus who wants us to do some magic and make them see better without having to wear the contact lenses which are commonly used. Among the refractive corrections, a majority of them do wear rigid contact lenses, and the options that we have, Bhaskar has already mentioned few of them. We can do topography-guided PRK to reshape the cornea. We can implant intracorneal ring segments. We can look at implanting phakic IOLs. We can think about doing stromal augmentation before we take the patient up for corneal surgery. And to arrest progression, we can do collagen cross-linking. But remember that these 4 options that I'm going to talk about in the refractive correction are limited to a very small subset of patients with keratoconus. A majority of them will still require to depend on a variety of contact lens wear. So topography-guided PRK, yes, it's basically indicated for very early keratoconus or patients who fall into the subset of keratoconus suspect. You need adequate pachymetry to begin with. I would say cutoff value of about 475. And the residual stromal bed should, the residual thickness should not be below 400 microns. You should get reliable and reproducible maps. And as Bhaskar was mentioning, that your refractive astigmatism and the topographic astigmatism should the axis match. If the two are not exactly the same, you may not get the desired outcome in that case. Explain to your patient this is not a refractive correction. This is just to reduce the astigmatism, reduce the high order aberration, so that at least with the spectacle they can achieve a better quality of vision. And often we combine this because you're removing tissue from the cornea. You want to strengthen the cornea as well, so usually we combine with collagen cross-linking, and sometimes some surgeons prefer to do the cross-linking first and then come back and do a topoguided PRK later on. So let's show you a clinical case. This is a 22-year-old female who has decreased vision in the right eye. The topography does show you that this is corneal ectasia, keratoconus. She had unaided vision of 624, improving to 69 with glasses, had a pachymetry of 488 microns, but she was not happy with the quality of the vision that she was having with the glasses, not willing to wear contact lenses. So we decided to do a topoguided PRK with cross-linking. But look at the treatment profile is different from what you do in your refractive surgery. Here, the laser ablation is happening. It's basically flattening the steep part and trying to steepen the flat part of the cornea. That is what you see in the difference map between the pre and post. You can see the flattening in the steep area and the steepening in the flat area. So the corneal asymmetry is reduced, which basically results in reduction of coma. Post-treatment, visual acuity was unaided was 612, and the best corrected vision was 6.6 with just 0.5 cylinder, and she was very happy with the quality of vision that she had compared to what she had pre-op. So there have been several papers which have looked at the long-term outcomes of simultaneous topoguided PRK followed by cross-linking versus cross-linking alone, and all of them have shown that these procedures are safe and they tend to give good visual acuity outcomes. But one of the concerns that we have seen in our clinical practices, sometimes you can get overcorrections. So always tend to correct the refractive error, maybe 80%, don't go for 100% refractive correction, because you may end up with patients becoming a little hyperopic in the postoperative period, and never treat both eyes at the same time. Always do one eye, see the outcome in that eye, how the patient responds to the combined cross-linking and the laser ablation, and then plan for the second eye. Intracorneal ring segments, yes, these are PMMA implants. There are various designs available. The common ones that we use in our clinical practice are Intacs. We use the Kera rings and the Ferrara rings. My experience has been mainly with the Intacs SK. They come in varying thickness. The arc length is what I use in my clinical practice is 150-degree segments. There are newer ones which are asymmetric thickness. That means they are thinner on one side, thicker on the other side. South America, they tend to use a lot of these rings, and they are the ones with the largest amount of experience. You can create the channel using the femtosecond laser, or you can use it manually, but majority of us, we create the channel using the femtosecond laser. Again, I don't use the Intacs SK for very advanced keratoconus. Use it for mild to moderate keratoconus and post-classic ectasia. The steep K preferably should be less than 58 diopters, at least when you start off with. The minimum thickness at the site of implantation should be 400 microns, absence of corneal scarring, and the patient, it's very important, should have realistic expectation, because the improvement can vary anywhere between 20% to 80%, and what the patient perceives as improvement and what improvement you see in your topography may be different, because some of these patients may also have myopic errors which will not get corrected because your astigmatism is going to come down. They will still need to wear glasses. That's a nice paper published by Narayan Netralaya. That's there in the Indian Journal of Ophthalmology. Basically, the treatment planning is done based on the location of the cone. If the posterior elevation cone is located centrally on posterior elevation, you put symmetric rings. If it is displaced, then you use asymmetric rings. You can put a single ring, or you can put asymmetric 2 rings, depending on the amount of myopic error they have. So that's where the spherical equivalent comes into play in the treatment planning, and also the mean K. That's just to show you how it looks clinically. That's one of the cases of moderate keratoconus. We did a single segment implantation of Intacs, and you can see the change in the topography after placing the intracorneal ring. And the visual acuity with glasses from 618 improved to 6.6 in this case. The astigmatism reduced from 6.5 to almost 4.7. So what we see is that basically by centralizing the cone or reducing the superior-inferior asymmetry, that's how Intacs works, and it helps improve the vision. There's again another case where a single segment Intacs was placed, and you can see the difference map shows you the amount of flattening that the the intracorneal ring induces. And sometimes after you do this, I usually do cross-linking a month later, but it can be done simultaneously as well. You can do, this is a patient who has keratoconus, best corrected visual acuity about 20/80. We first did the intracorneal ring implantation, and then you can see that the cone has become central, but the patient had a refractive error of -2.75 with -4 cylinder. He was still after me that, no, you have to do something else to make his vision better. He had good thickness, so we went ahead, did a topography-guided ablation. So we first did the intracorneal rings, then we performed the topo-guided PRK with cross-linking, accelerated cross-linking, and that's how his corneal topography turned out to be. He was almost 6'6" after the treatment. So you can use a combination of treatment to achieve this. Phakic IOLs, yes, there are a lot of papers looking at various designs. Both the Verisize and the toric ICL have been used alone or in combination with intracorneal ring segments or topography-guided ablation with successful outcomes. So basically, you need a stable keratoconus. The patient's best spectacle corrected visual acuity should be 20/40 or better, and he should be happy with that visual acuity. It's very important to explain the patient that the implantation of the phakic IOL will basically give him the same vision what he has with the glasses. It's not going to make it better. The astigmatism should be less than 6 diopters, and the other parameters as per the phakic IOL requirement. So that's again the clinical case showing you the change in the refraction from -9 with -2 cylinder. You can see it's almost planar after the phakic IOL. The topography should be such that the astigmatism within the pupillary area should be almost regular. There should not be any irregular astigmatism. The last one was stromal augmentation. This is again has been implanted. I'll just take 30 seconds more. So this is how the technique is done. Using the femtosecond laser, you can create a pocket. This was created at the depth of 200 microns. And I put in a 100-micron stromal lenticule measuring 8 millimeter in diameter. And when we started doing this, we used to cross-link the lenticule, thinking that the cross-linking will make the lenticule stronger, and the patient will not require a separate cross-linking, and this alone would suffice. That's how it looked post-operatively, and 6 months later, we would do now because the thickness is adequate, we do a topo-guided PRK with cross-linking. That's the change following lenticule, and then after the topo-guided PRK with cross-linking. For the series of 12 patients we did, you can see that the best spectacle corrected acuity improved from 618 to 69, and the thickness, although we did topo-guided PRK, the thickness was still more than what we started off with. There was significant reduction in both the high-order aberration and the coma as well. So basically, these are the 4 options in refractive corrections which can be considered, but like I said, that you cannot implement them in each and every patient of keratoconus. Careful selection of patients and explain the patient. Sometimes one procedure may not be sufficient. You may need to do multiple interventions. Definitely can help achieve your patient independence from the contact lens wear. Thank you. Thank you for your patient hearing.
Thank you, Dr. Rajesh. Till Dr. Vanathi sets her talk up, you have now shown various options of improving the refractive results of patients. But what would be your choice if you have somebody with a very thin cornea or with a very steep cornea? Would you want to do a DALC as a choice, or would you want to prefer stromal augmentation or CARES or ring segments as a choice?
I think it depends on what the patient wants, because both, when you do stromal augmentation, it takes time for the vision to improve. When you make a pocket and put in the lenticule, the first day the patient will have a significant drop in vision, and it takes almost 4 weeks for that stromal edema and everything to settle down, and for the patient to go back to the pre-op vision that they had. And thereafter, before you can do a refractive correction, the topography and everything has to settle down. So at least we are looking at 3 to 6 months later. So if you have a patient who's willing to wait longer and understands the kind of limitations the procedures have and what kind of final visual acuity we can achieve, then yes, doing this stromal augmentation, following up with a topo-guided PRK is a good option. But if a patient doesn't want to bear the expense of multiple surgeries and they want a definitive procedure, then maybe a DALC is a much more, it's a procedure where you have the outcomes are much more definitive than the other one.
Because the question always is there in terms of the cost that the patient has to pay for the multiple steps.
Correct. So that's what I say, that I have to sit with my patients. So now we have done some patients where we have taken the lenticule, done a laser ablation on the lenticule itself before implanting. So we don't put a planar lenticule. We put in a lenticule where the center is thinner, the periphery is thicker. So we are trying to emulate what we do on the surface ablation. We are ablating the lenticule first and then putting it inside with the expectation that the central cornea will flatten a little bit so that later on when you do a topo-guided PRK, you have to do a less amount of ablation and remove the tissue. And you can implant that lenticule a little superficial. In the initial cases, we implanted them at 200 microns depth. But the deeper you implant, less the impact, you get a change on the anterior surface. You see more changes on the posterior surface. So if you want to implant the lenticule a little bit more superficial, but then you won't have enough amount of stromal tissue in the front to play around with the laser ablation later on. So you have to, it is still a gray area where a lot of things we have to still understand. And I think in the future, stromal augmentation will become a treatment, like a treatment of choice for managing keratoconus because it's an additive procedure.
That was fascinating. Can I ask a quick question? So in line with that stromal augmentation, have you thought about ever putting, compression sutures at the periphery to try and flatten the center?
We tried after putting the lenticule in, we tried putting running suture all around. But the problem is once you tighten the sutures make the central cornea become steeper.
Right.
So the cornea behaves like that. It's not a rigid cornea, it's a pliable cornea. So when you tighten the suture in the periphery, so either you'll have to have, instead of running, maybe you'll just have interrupted suture, which pulls only the lenticule, because once you compress the host cornea as well, it doesn't work.
Right. No, I meant the donor cornea only, and put that, tuck it in.
But there are a few things which are in the pipeline. There is something else coming up, which is a biocompatible implant which can be put into the pocket, which is more rigid, and that will help the cornea retain the shape better. So the future, there's a lot of work going on. Maybe 5 years from now, we'll be treating keratoconus in a different way.
Thank you, Dr. Rajesh. And now Dr. Vanathi will be talking on pearls to perfect DALC and PK.
I've opened it, it's not coming. I have to connect it. Achha. The next talk will be by Dr. Ritu Arora. The volume is not on this
session, but I am sending you my recorded version. Thanks to Dr. Vanathi for making me part of this instruction course and sharing my views on keratoplastic concerns and keratoconus. As you know, now with the advent of cross-linking, keratoplasty in keratoconus has become much lesser, though keratoconus patients are in the excellent prognosis for keratoplasty. I have dealt with this topic, dividing it into different parts as to when to resort to keratoplasty, in case I decide to do keratoplasty, what to do, and which part of the keratoplasty to be taken, and how to go about these different surgical options. And the when part of keratoplasty comes, that when we are dealing with advanced keratoconus, we still have in our country patients presenting to us with markedly advanced conus, especially in children. When the thinnest cornea may be less than 350 microns, we do get patients with thinnest cornea less than 200 microns also presenting to us with markedly diminished vision and keratometry going to 70 and 80. Other indication for doing surgical intervention and cross-linking is not possible for whatever the criteria may be. Or in cases when sometimes the cross-linking has been done and with whatever best options, the best corrected visual acuity is not improving and we are dealing with a young patient in front of us. Another indication at times is when we have a central healed hydrops and there's a conus with advanced scar. It's not uncommon, especially to see patients in my kind of a practice when they present with conus with central thinning area 280 microns, and so there's no other option left except to resort to a surgical intervention. Or when they present to us with healed eye drops with a scar in the central area. So after we have undertaken the thing that we are going to do a surgical intervention, there are different multiple concerns. Though surgically, they are all in the excellent grade for prognosis for management, but the concerns which may come when they have associated, because a number of them have associated vernal keratoconjunctivitis with them. It is this VKC, they may come with advanced papillary reaction, cobblestone papillae, and these need to be managed before any kind of an intervention, even cross-linking or a surgical management is done, because these are the ones which are constituting the environment or the milieu for the eye, for the cornea. So the management of these become very crucial, especially when the patient is to be taken for a surgical intervention. We manage them with giving them high-dose topical steroids, may need immunomodulators, and that is the time when the papillae resolve and they are taken up for the surgical intervention. They may have an associated dry eye because of the conjunctival goblet cells being completely damaged. Because all these will alter the surgical management in keratoconus patient. Because of the associated VKC, they may have peripheral vascularization and even limbal deficiency, which comes in the way of surgical management of these patients. Number of times, the recipients are younger in age, so they may be pediatric age group or they may be in teens, so the surgical management and the concerns are what as we do the pediatric PKs, because they have a hyperactive immune system. In case we decide to do that surgery has to be done, the surgical intervention would be whether we are going to do a penetrating keratoplasty or we are doing a deep anterior lamellar keratoplasty. I have not dealt with other surgical managements like intracorneal rings and Bowman membrane transplantation, because they are also being done in these cases of conus. As far as possible, whenever I have the choice, I like to perform a deep anterior lamellar keratoplasty and definitely like to attempt a big bubble. And though there are multiple techniques described for formation of big bubble, Dr. Fogler has already talked about whether we are going to be using the cannula over there or we use AIOC2022 so as to know what the needle placement is. But word of caution, if you have a keratoconus with high drops, avoid forming a big bubble over there. The bubble formation is not difficult because as we go with a 30 gauge needle, the needle track or the view is all along there. And try and get across to the paracentral area with the tip of the needle. That is when you get 100% bubble formation. In case one is not successful in forming a big bubble, go layer by layer so as to preserve the Descemet's membrane. And always have a standby good quality of cornea even you're attempting the DALC so as to avoid in case the perforation takes place. This is my technique of forming a bubble. I go my needle paracentral and then slowly inject with the 30 gauge needle and 2 ml syringe, forcefully bubble formation takes place, and this is not difficult. And as far as the trephination is concerned, I like to take large grafts. They may range from 8.5 to 9 millimeters. I've even dealt with 9.5 mm post trephinations. Like to do the same post and the donor so as to correct the myopia, and also I've seen the disease progresses over the period of time. So there may be recurrence of the disease in the donor cornea. So it's like better to take large grafts. Max, if I oversize, is by 0.25 millimeter. If I do penetrating keratoplasty, Definitely will do a peripheral iridotomy, especially under the traphind edge, so that it does not become a cosmetic issue later. Pupil is always constricted so that we don't land up with a dilated fixed pupil post-op. Always use an excellent grade donor tissue, and I always use interrupted sutures because I'm using a large graft. Do not dilate the pupil in the post-op period so as to avoid Poirot-Chevalier syndrome. Because we are operating on young recipients, rejections take place, but they can be easily reversed. So always be on the lookout for these findings. And these cases are excellent graft and vision prognosis. They may be associated with large astigmatisms, which need management, especially with the use of contact lenses. Since we are operating on patients who have pre-op VKC, we do see shield ulcers also in these cases, which of course heal with proper management. And also always remember that the limbus in these cases is not healthy, so it may land with persistent epidefects. The other important concern, because of over the long time, when we follow up these patients over 10 years, 15 years, I've seen if the smaller graft is used, we get recurrence of keratoconus in the grafts. And this is another patient who had recurrence of conus in the graft, was being managed with sterile contact lenses till he landed up with eye drops in the graft. And eye drops in a recurred cone in a graft always starts from the host graft junction when the descemet membrane clears from the host graft junction, but can be easily managed with intracameral gas or air. And this is the patient which I can show you, and this patient is now following up even 6 years after management of the recurrent conus in a graft area. So always remember, and these cases may be mistaken as cases of graft rejection, though they are just a recurrence of cone in a case of graft. Another surgical issue which comes that they may have associated other ectatic conditions like PMCD or diffuse thinning and ectasia. And these are cases where they don't do well with simple PK. They need to be managed with lamellar, anterior lamellar surgeries, or we may have secondary conus post-LIS ectasia. They need large dial or tilk. So in nutshell, I would like to concise my thing saying that surgical treatment in keratoplasty in conus should be deferred if possible. Once we decide to do what to do, prefer DALC over PK and always use good grade cornea. Thank you very much.
I think that was indeed a comprehensive coverage of all the practice concerns which arise when we are seeing keratoconus, which does form a bulk of our practice when you are cornea-focused practice. And I do thank all my speakers for their fantastic presentations. In the interest of time, I think we will have to hand over the hall. We thank our audience for being patient and listening to us for so long. And if there are any concerns which you would want to discuss with us, we welcome you to address the questions to us, please. If there's nothing, I think we'll conclude the session. Thank you once again, and may I invite the instructors on stage for a group photograph.